and talk about everything you want to know about the liver in a whirlwind of about 45 minutes. So these are my disclosures, and we're going to start with 5 unknown cases. So don't have to write these down, just remember these. We're going to cover all these things on the course. So this is case 1. This is case 2. This is case 3. This is case 4. And finally, case 5. So if you got all those, great. If you didn't, we'll go through each and every one of these entities now. So what we're going to talk about is a little bit of liver anatomy. We're going to talk about diffuse liver diseases, especially important liver diseases uptrending in the United States of metabolic associated liver disease. We're going to talk about benign lesions. We'll touch into cirrhosis and then go into malignant lesions of the liver. So brief anatomy, when we look at gross anatomy in medical school a long time ago, we looked at a couple lines. Surgeons, when they open the abdomen and look at the liver, they're looking at this Cantley's line, which goes from the IVC to the gallbladder fossa, which is where they denote where the demarcation is between the right and left liver. The falciform ligament is the demarcation to them between segments 2 and 3 and 4. But this is not exactly what they use when they're talking about how to go take out tumors or do resections. What they're using is the Kuhnel classification. And so this is what they're using and what we use in radiology as well. These are 8 functional hepatic segments that each have their own hepatic artery, portal vein, and bile duct. And the one exception to that is the caudate lobe because it drains directly in the IVC. And when you look at this and you know, how do they come up with this system? It really looks like a clock face. If you think that if this is segment 1 and you look as a clock face 2, 3, 4, 5, 6, 7, 8, it's almost like a clock face what they're looking at. Again, on cross-sectional imaging, it makes no sense. So, but that's how it goes. In terms of the hepatic parenchyma, the liver should be very homogeneous on CT and MRI. On non-contrast CT, a normal attenuation, if you took an ROI, should be about 40 to 70 Hounsfield units, and it should be brighter than the spleen. On contrast CT, the attenuation varies. And because of the...
So I'm going to talk about the adrenal glands. I have on here a challenge case. This thing right here is the adrenal gland, I'll just say, in this particular case. Okay, and then I have no financial disclosures or any other disclosures to make. So I want to make 4 key points for this lecture. The first thing is that most adrenal nodules are benign. And fat content in an adrenal nodule usually, but does not always mean it's benign. Washout characteristics usually, but does not always mean it's an adenoma. And the things you really want to look out for are the size, the heterogeneity, and rate of growth. And there's a couple other things that we'll talk about as we go through the lecture, but it's basically the idea is that if you see an incidental adrenal nodule and it doesn't look right, then don't just rely upon fat or washout characteristics to say that it's just an adenoma or something that's benign. Okay, so the anatomy, very briefly, we have 2 parts to the adrenal gland. Most of the pathology we'll be talking about is arising from the cortex, which has 3 layers that we can't really distinguish with a CT or MR for the diagnostic radiology, which control mineralocorticoids, glucocorticoids, and androgens. And the thing I want to point out about this is that because these produce a lot of steroids, they have the steroid precursor, which is esterified cholesterol. So that's why adrenal glands have a lot of lipid inside of them. And then centrally, we have a second thing, which is the medulla. And this is a neural crest derivative. This is what secretes epinephrine into the bloodstream. And you can refer to the different parts of the adrenal gland based on either the body or anterior limb, the medial limb, and the lateral limb, if you need to be more specific. But in most cases, it's not necessary for us as radiologists to specify which limb or part of the adrenal gland is involved. Okay, so back in 2010, there was a white paper released by the ACR which talked about how to manage various incidentalomas, and adrenal incidentalomas was part of that. Don't worry, I'm going to blow this chart up. In 2017, they had a revision to this. Now again, this is a white paper. It's not officially a guideline, it's not policy, and it doesn't cover all of your bases, but it's thought to be a decent guidance, and so we'll go over this to start with. So the first thing, step one, if we can decide right away that your incidental adrenal nodule is just diagnostically benign, then
So we're going to talk a little bit about neuroimaging and dementia and neurodegenerative stuff, right? You know, I don't know how many of you have been following, but Alzheimer's disease has gotten really controversial, right? We now have some medications that really are supposed to decrease amyloid in the brain, and it's a little bit interesting. So the controversies are out there because they don't really seem to be super duper effective, and in fact, the European authorities have not really approved it, but we have approved it in the US and some other places, and it's uncertain. You know, very early on in disease, it seems to slow symptomatic progression, but whether or not it actually slows the disease, we don't really know. So it's uncertain whether or not this amyloid hypothesis is valid, but nevertheless, we have a bunch of new medications that are on the market that some of you will be seeing the follow-up imaging for. So we'll talk about that, and that's pretty important. So as we go through normal imaging, and I like using the royal we because apparently I'm not immune to this, things happen to the brain, among other things, you know. So in general, I'm going to be talking about shrinkage, but generally of the brain. Any other things I'll leave to Dr. Richmond because she talks about the other things that may shrink. But in general, with normal imaging, what happens over time is that your brain may actually decrease in overall volume. That doesn't necessarily mean that you're getting dumber, you're getting stupider. It's just, you know, as part of aging, our volume decreases. We're not quite as watery, we're not quite as wet. That happens to our discs and all sorts of stuff. Our white matter may get abnormal. We may get some dots in our white matter, and then our perivascular spaces may enlarge too. But I differentiate between just normal aging, where we lose volume of our brain. Some of it may be dehydration, some of it may be other stuff, and I distinguish that from atrophy. Because when you think about pathologically, atrophy is actually loss of volume of cells, and oftentimes is related to cell death. So in comparison to volume loss, when you actually have atrophy, you have cellular loss and cellular death. So in standard aging, your cortex volume is generally preserved. So once we start talking about some of the areas of neurodegeneration, we're going to start seeing that cortical volume start decreasing. So as we talk about volume through the ages, I'm trying to get a little bit of Def Leppard vibe in here, you know, through the ages. Okay, nobody's old enough to remember them, but that's all right. So when you look at this over time, as you're young to when you get progressively older, what we see in these normal brains is that the volume of the brain starts getting smaller, the ventricles start getting a little bit bigger, and the cell size start getting a little bit bigger as well. And all of this is proportional. But yet, when it's just volume loss, you can see that the cortical brain, the cortical gray matter, is actually fairly well preserved. And over time, all of us develop these white matter signal abnormalities. I know classically in the old days, we used to call them UBOs, unidentified bright objects.